Good afternoon, everyone. As Dr. Chan said, I'm Cheryl Wisseh. I am an assistant health sciences assistant clinical professor at UCI. And through this work, I also have an appointment at Charles Ardrey University of Medicine and Science, and I am a clinical scholar there as well. Next slide, please. So we'll be discussing the social determinants of pharmacy deserts. So exactly what are pharmacy deserts? What does this concept mean? The most well-known definition are those communities with no pharmacy within a 1 mile radius, or communities with limited vehicle access and no pharmacy within a half-mile radius. And this definition was adopted from the USDA and CDC definitions of food deserts. So while pharmacy deserts are not a new concept, our study was the first to identify and characterize the pharmacy deserts in California, more specifically in LA County. Next slide, please. So let's talk really briefly about the social determinants of health. These are the conditions and environments in which people are born, where they live, work, play, worship, and age. They have these different domains, as we see here by the infographic. They include the social and community context, economic stability, education, neighborhood and environment, so that built environment, and then healthcare and healthcare access. They're real and immaterial, or intangible resources that can affect the quality of life and health and wellness outcomes. And depending on which side of the tracks you live on, they can be life damaging or life enhancing regarding an individual or a population's health. That's why it's important to characterize the types of deserts by the social determinants of health, because once again, it can be life damaging or life enhancing because everyone has them. So to reiterate, what makes our study different from all the other studies is how we define the desert. So we use that criteria of 1 mile or greater away from a community pharmacy to identify all of the deserts in LA County. And then we use those social determinants of health population indicators to explicitly characterize the types of deserts in LA County. Thus, the desert types are conceptualized in the Healthy People 2020-2030 Social Determinants of Health framework. Next slide, please. So the population level data that we use to approximate or represent those social determinants of health indicators included the ACS data from the American Community Survey from 2010, federal poverty level, household ownership, vehicle ownership, education attainment, the language spoken at home, health insurance status. And then we have some census data looking at race, ethnicity, and age, and then crime data looking at crime within those census tracts or those communities against people and property, and then some of the health resources and services administrative data looking at health professional shortage areas. So in regards to our analysis, we extracted the community pharmacy, so only community pharmacies, not ambulatory clinic type pharmacies, from the California Board of Pharmacy licensee database and geocoded them and then from the street network distances, we calculated how far it was from the census tract centroid to the nearest pharmacy. Once again, that community pharmacy. And the pharmacy deserts were, again, defined as being more than 1 mile in that road network traveling distance. And what we did, we use a K-means clustering analysis to partition the pharmacy deserts into different types based on their composition and typology. And we map these results with GIS. Next slide, please. Excuse me. So what did we find? What did we learn about pharmacy deserts and non-deserts in LA County? So just a little tidbit about LA County, it's divided into 8 geographical service planning areas. And this is done by the Department of Public Health for planning and implementing public health and clinical programs based on the needs of each area. This table just displays that distribution of pharmacy deserts and non-deserts in Los Angeles County by those SPAs, or the service planning areas. Of the 2,323 census tracts in LA County, we found that 571 of them were pharmacy deserts based on our definition, and 1,752 were non-deserts. Interestingly, San Fernando, which is SPA 2, had the largest population and number of pharmacy deserts and non-deserts overall, which is not surprising because of the large population. And on the other hand, the West SPA had the least number of pharmacy deserts and the second smallest population overall. This is also not surprising, but then it speaks to how exclusive those communities are that make up those service planning areas. Next slide, please. So upon further analysis, looking at the desert types, two distinct types of deserts were identified by clustering those social determinants of health population indicators. Type 1 deserts, there were about 238 of those census tracts that were considered type 1, and then type 2 deserts, there were about 333 census tracts that were considered type 2. So in comparison to type 2 desert residents, type 1 desert residents live in areas that potentially could compound the negative effect of having that shortage of a pharmacy near them or those pharmacy services, so that distance being greater than 1 mile. In type 1 deserts, they contain denser populations. So when you think about the residents per square mile, it's definitely denser in those communities, more non-Hispanic Black, more Hispanic, more renters, more that speak English as their second language. So there could be some linguistic isolation, less vehicle ownership, more we're living under the federal poverty level, more we're living in areas with higher crime against property and people, and they had less health professionals to serve the area and less had health insurance. So in comparison to that, with type 2, you have type 2 desert residents. They live in areas with less of the residents lack health insurance. There's a less dense population overall in regards to residents per square mile, less non-Hispanic Black, less Hispanic, less renters, or those that speak English as a second language, less were living below the federal poverty level, and less living in areas with crimes against people and property, and more healthcare professionals to serve the area. So this just demonstrates a key point that there's an inequitable distribution of those social determinants of health within the pharmacy deserts. And it's this same inequitable distribution of those social determinants of health that is the driver of the health disparities that we see, whether they're along the racial, ethnic, or socioeconomic dimension. Next slide. So just to zoom in just a little closer, as stated earlier, Los Angeles County is divided into those 8 geographical service planning areas. So just taking a closer look at a tail between these 2 service planning areas who are right next to each other. So we have SPA 5 and SPA 6. So here we have the notable communities. So notable communities in SPA 5 include your Beverly Hills, Malibu, Venice, Santa Monica, places known for affluence. And then in regards to SPA 6, you have Compton, Watts, Athens, and Crenshaw, areas with high numbers of racial ethnic minorities living there. In regards to the pharmacy desert types that you found in each, we found that there were 0 type 1 deserts in SPA 5, whereas all 100% of them were type 2. However, you have 54 type 1 deserts in SPA 6, whereas there's only 4 type 2 in SPA 6. In regards to the geography, there's urban and suburban mixtures between both. One thing that was striking, there were 1.22 pharmacies per 1,000 residents in SPA 5, but there are only 0.26 pharmacies per 1,000 residents in SPA 6. So in terms of magnitude, there are almost 5 times as many pharmacies per 1,000 residents in SPA 5 than there are in SPA 6. And then you see that in regards to residents per square mile, about 3,300 residents per square mile in SPA 5, while there are 14,000 residents per square mile in SPA 6. And then in regards to that racial ethnic makeup, you have it's majority non-Hispanic white in SPA 5, but SPA 6 is majority Hispanic and non-Hispanic Black. In regards to what in regards to what this may mean, so the impact. So all the pharmacy deserts are type 2 in SPA 5, but our data shows that these residents are lacking access to community pharmacy based on that travel distance. However, when you think about it, more of the residents in this area have vehicles. They're living in suburban areas where the pharmacy might be spread out geospatially by the design, more have health insurance coverage, and there's more healthcare professionals to serve the area. So that access to the pharmacy just by the distance may not be burdensome, but on the flip side, if in SPA 6, you have residents who don't have vehicles, they live in areas where crime is higher. They lack health insurance, may not speak English as their first language, and less health professionals to serve the area. So all of these aspects contribute to what I call that distance traveled, and impose barriers to getting to a pharmacy. Next slide. So this is just showing on the map the different service planning areas by those demarcated by those borders. In the red, we have the West Spa, and then in blue, we have Spa 6. So what we need to consider is that from the historical perspective, prior to that civil rights movement, you had discriminatory practices such as redlining, which contain people of color in impoverished and densely populated neighborhoods, while you had non-Hispanic whites out-migrating to suburban areas, such as those seen in Spa 5. And while this no longer exists, there's no redlining, there's been a series of race riots, economic forces that have increased housing costs and immigration that all contribute to the persistence of that predominantly minority communities that we see in Los Angeles. More specifically, as seen here, you have Spa 6, which is 68% Latinx and 27% Black. And then you have Spa 5, which is 64% non-Hispanic white. And I just want you to note how spatially, how big the Western Spa is compared to the South Spa. Next slide. So just to wrap everything up, the take-home points for this conclusion is that the causes of this divergent and inequitable distribution of social determinants of health factors in these type 1 and type 2 pharmacy deserts definitely have historical formation and structural inequity, which contributes to that population migration in Los Angeles County. There are definitely market forces that play a role in the formation of pharmacy deserts, such as closures and different competition for market share, but that's not the point of this presentation. There's a need for a more in-depth analysis of the population health implications and consequences. So residents in these different service planning areas might benefit greatly from equitable, innovative, community-based interventions that increase access to medications, pharmacy services, and pharmacists. All right, next slide. Thank you. Next slide. Oh, and these are just my acknowledgements. So they say it takes a village. I just wanted to acknowledge Dr. Paul Robinson, who's the health geographer and senior author on this work, and several programs at CDU, my fellowship program, CRCD, the Access Program, the Urban Health Institute, and of course, my community mentor. With all of them, without their support, this presentation and project would not have been possible. Thank you.